Hello, folks. Today we're going to be talking about substance-related and addictive disorders. We're going to start by reviewing alcohol and then moving to some of the other substances, um, including stimulants, hallucinogens, and then move through to gambling disorder. So, in this section, you're going to see a lot of comorbidity that occurs with substance abuse. Some of you going into some of the more specialized fields. I know some of you are interested in public health, epidemiology, and nursing, as well as some of you who might be more interested in treating substance use specifically. We'll probably find this lecture, textbook, and accompanying videos to be interesting. You'll see that this is often a very specialized area and affects quite a large number of people. So as we go through today, you'll notice some of the overlap with some of the other disorders. So let's just begin by talking a bit about substance use disorders more broadly. Previously, the DSM-4 had talked a bit about substance abuse versus substance dependence. That's actually been eradicated. The disorders are now just defined as just use disorders and are ranked on severity from mild, moderate to severe. So they've done away with a bit of the distinction there. And I've moved away from the term addiction, generally because of the stigma that's associated with it. And substance use disorders are characterized by a cluster of symptoms, including cognitive, behavioral, and physiological symptoms. Some of these might be failure to meet obligations, either in terms of the family life, responsibilities at home or at work, the repeated use of substances in physically hazardous situations, so while operating machinery, vehicles, physical danger that might occur, legal problems that might come about, and certainly interpersonal problems that might come up. So there's a variety of symptoms that can come into play with substance use disorders. Clinicians generally diagnose substance use disorders by assessing an individual across 4 categories of symptoms. These might be impaired control, the social impairment that occurs for the individual, the risky use, again, driving, the risk for example, like sexually transmitted infections that might occur through needle use, and certainly pharmacological changes, so actual differences that are occurring either within the brain or within the individual's physiology. So just in terms with substance use disorders, I just want to talk briefly about some of the associated features. Generally what we have is substance intoxication. So this would be the temporary maladaptive experience of behavioral or psychological changes that are due to the accumulation of a substance in the body, right? So this would be, in layman's terms, in getting high, getting drunk. That's what we mean just here in terms of substance intoxication. Many of you may have heard of withdrawal, the physiological and psychological changes that occur when an individual stops taking a substance. Generally, you'll see more withdrawal symptoms in an individual that previously had met for substance dependence, right? So again, that's been eradicated. So you'll see withdrawal if it's depending on the severity of the disorder, the greater the severity, the greater chance you're going to see withdrawal symptoms. And these might occur differently depending on the substance of interest. And some of you also may have seen tolerance, so the extent to which the individual requires larger amounts of a substance in order to achieve its desired effects, or the extent to which the individual feels less of its effects after using the same amount of the substance. So generally, when we're dealing with substance use disorders, you'll see these 3 associated features in some capacity. Okay. So let's talk a little bit about some of the disorders associated with specific substances. Just in terms of substance abuse, more broadly, most drugs are directly or indirectly that target the reward center of the brain. And oftentimes this is done with dopamine specifically. We'll talk a little bit more about that particularly as it relates to stimulants. This overstimulation of the reward system produces a lot of the euphoric effects that abusers seek, and leads them to repeat the behavior in order to repeat the experience of those euphoric effects. So there's very much a conditioned response that takes place at the physiological level with substance abuse. Just to kind of give you an idea, approximately 9% of the general population are current users of illicit drugs, right? And so, marijuana is included here, and that's going to be the most commonly used illicit drug. So quite common. To give you an idea just about some of the comorbidity that occurs, if we're looking at the use of any drug coupled with mood and anxiety disorders particularly, you'll see that it's an extremely high prevalence rate. You're very rarely likely to see somebody that is suffering strictly from a substance use disorder. There's very often comorbidity that occurs, as you can see here. It is important to keep in mind when looking at this graph that this data is correlational, right? So it's not necessarily, there's no necessarily any one mechanism here through which depression is leading to substance abuse or substance abuse is leading to depression. It's important to keep in mind that this data here is correlational. So the mechanisms of change are certainly up in the air, especially depending on what disorder we're talking about. But it is important to note that that there is a very high correlation among the substance use disorders. So let's talk a little bit first about the alcohol effects. So many of you are likely to be familiar with this already, either depending on personal experience or past study. So alcohol is a depressant. So when we're talking about a depressant, we're thinking of a psychoactive substance that causes the depression, specifically of central nervous system activity, right? So if we're thinking about some of the immediate effects of alcohol, we have sedation, again, the central nervous system winding down. It can be, of course, potentially fatal in excess, right? So some of you may know from experience, in smaller amounts, alcohol has sedating effects, leading its users to feel more relaxed. And on the other side of the coin, in larger amounts, alcohol may lead drinkers to feel more outgoing, more self-confident, more uninhibited. As the drinking continues, alcohol's effects as a central nervous system depressant become more apparent, especially as sleepiness or uncoordination, dysphoria, and irritability begin to set in, right? And the excessive drinking can affect vital functions in an individual and can, of course, can be fatal. Something else to consider with alcohol and the other drugs that we're going to be talking about is the idea of potentiation. So this is the combination of the effects of two or more psychoactive substances such that the total effect is greater than the effect of either substance alone. And this is where this gets really dangerous with both with alcohol and any of the other substances that we're talking about, is that the mixing can become very deadly. Some of you might be familiar with John Belushi, famous comedian. He was killed by using what's referred to as a speedball. This is a mix of heroin and cocaine. And so, you'll see plenty of examples, especially, in the media of individuals mixing drugs together to, come up with a potentiation that's going to be deadly. So that's important to keep in mind as we go along through and look at individual substances here. If we're looking at some of the more long-term effects of alcohol, these exist as well. So there's certainly going to be the potential for permanent brain damage. We'll see this especially in the forms of dementia. One of the forms that we have here is Wernicke's aphasia. So this is Wernicke's disease. So this is a form of aphasia in which the individual is able to produce language but has lost the ability to comprehend it. So that any of the verbal productions that this person would have no meaning, right? Some of you may have also heard of Korsakoff syndrome. So this comes about after very heavy alcohol use. So this would be a permanent form of dementia that's associated with long-term alcohol use, in which the person develops retrograde and anterograde amnesia. So this leads to an inability to remember recent events or to learn new information. So if we're, just to define it for you, if we're thinking about retrograde amnesia, this is amnesia involving loss of memory for the past events, and the anterograde amnesia is amnesia that involves the ability to remember new information. Okay. Additionally, in terms of some of the harmful changes that come about in the liver, gastrointestinal system, bone density, muscles, and the immune system. So just in terms of thinking about some of the prevalence rates, you'll see that binge drinking is a really big problem, especially in terms of college samples. So just to kind of give you an idea of what this looks like, you'll see it really shoot up in terms of the 18 to 20 bracket, and then the 21 to 25. That begins to taper off, but you can see that it's still quite prevalent. Some people would say that it's a problem, other people would not. You know, it could be it's certainly contested, but it's certainly a phenomenon that occurs. There's a variety of theories and treatment in terms of alcohol use disorder, right? So in terms of some of the biological approaches, some of the twin, family, and adoption studies consistently point to the importance of genetic factors as contributors to alcohol-related disorder, right? You see quite a degree of heritability that occurs. Genetics of alcohol-related disorders come from studies that examine associations with genes that are involved in both alcohol metabolism and neural transmission, right? There's a variety of medications that come into play in terms of the treatment of alcohol use disorder, right? So oftentimes people don't necessarily think of a substance treating a substance, but they certainly exist. The first there is naltrexone. So this blocks the effects of the body's production of alcohol-induced opioids, and this is done through dopamine. So you'll see that dopamine continues to play an important role across substance use disorders. Next, you'll see that there's the disulfiram. So this is known popularly as Antabuse, and this is a medication used in the treatment of alcoholism that inhibits ALDH. So this is aldehyde hydrogenase. Excuse me, you don't need to know that specifically. But the important thing to keep in mind is that the Antabuse causes severe physical reactions when it's combined with alcohol, right? So it helps inhibit some of that conditioned process that's already occurred for the individual. And lastly, there's a comprosate. This excuse me, reduces the risk of relapse by reducing the individual's urge to drink and thereby reduces the drive to use alcohol as a way of reducing anxiety or other negative psychological states such as depression. So, you know, there's a number of ways through which we can treat substance use disorders with medications. There's certainly psychological theories in treatment, right? So we have dual process theory. This suggests that there are automatic processes that generate an impulse to drink alcohol and controlled, effortful processing that regulates those automatic impulses, right? You know, so the idea that we're coming at this from two different processes. Alcohol myopia theory proposes that as individuals consume greater amounts of alcohol, they're more likely to make risky choices because the immediate temptation of the moment overcomes the long-term consequences of the behavior, right? So it's obviously much easier in the moment to simply say, okay, I'm just going to have this one drink, you know, without thinking about taking in more alcohol and what the consequences, whether they be, you know, physical, social, are going to be in the long term there. Generally, alcohol-dependent individuals show a variety of behaviors, right? So this might be early neural dysfunction, nervousness and fretfulness as the drinking continues, hyperactivity as children, poor physical coordination. So some of those things are important to consider, at least in terms of some of the biological perspectives. In terms of some of the sociocultural concerns, we regard family, community, and cultural stressors. As we have for many of the other disorders, like to what degree is an individual witnessing alcohol use in the home? How, in terms of community events, if we're thinking about, children going to holidays and seeing alcohol regularly, how frequently is alcohol being used? That kind of exposure is going to have a greater effect on the outcome for alcohol abuse in the future. And then in terms of some of the treatments that exist in terms of the psychological approaches, certainly cognitive behavioral interventions take place. You may recall from earlier we talked a little bit about motivational interviewing, so eliciting change talk from the client. Why is it that they're choosing at this time to quit? What is it in their life that's important to them, or what do they value that is going to be leading them to quit? Bringing up that motivation. Expectancy manipulation, right? So having a client earlier on in therapy recognizing that they can make a change, and that people who have been in their position have made changes in the past. Relapse prevention is certainly very key. So, this is going to be based on the expectancy model. This is in which individuals are encouraged not to view lapses from abstinence as signs of certain failure. So, recognizing that, people may stumble, but that certainly doesn't mean that they have to completely abandon progress that they've made so far. And then there's combined behavioral intervention. So the primary emphasis here would be on enhancing reinforcement and social support for abstinence. So a number of psychological and cognitive behavioral approaches that come into play. Moving away from to substances other than alcohol, and there's certainly a variety of them. I'd like to start with stimulants. So these are substances that have an activating effect on the nervous system. This category of drugs includes cocaine. So this is going to be a highly addictive central nervous system stimulant that an individual can snort, can inject, can smoke, and they're going to be different names. So you may have heard of crack cocaine before. This would be a variation that an individual can smoke. So there's quite a few ways in which an individual can consume it. Here the effects include different feelings of euphoria, heightened mental alertness, reduced fatigue, and heightened energy, right? So we see this going in the other direction of alcohol, which has a more depressing effect. In this category, there's also amphetamine. So the amphetamine affects the central nervous and the autonomic nervous systems. And there's also methamphetamine. Methamphetamine is related to amphetamine, but provokes a more intense central nervous system effect, right? And a lot of times when we see across some of the different drugs, psychotic features that come about. So we talked a little bit about some of like the delusions and hallucinations in the previous chapter. Methamphetamine can cause psychosis in nearly 2/3 of users. So it's important to recognize earlier on, if an individual's suffering from a psychotic episode, before we jump to either a schizophrenia diagnosis or a brief psychotic disorder, we want to make sure that we're evaluating what that individual's substance use is like. We're looking at frequency, duration, keeping all of those factors in mind. Also looking at early childhood history, doing a full in-depth evaluation to determine what's bringing on psychotic features, because as you can see here, the stimulants can sometimes be responsible for that. To give you an idea, this figures in your text, right? But we see that the cocaine can have a specific neurological effect, right? So if we look at this image here, we see the presynaptic neuron that the cocaine can latch onto the cell's autoreceptors, right? So you can see up in the little circular little dotted circle up top there that the dopamine has, that the cocaine has latched onto the autoreceptor, which is keeping the dopamine in the synaptic cleft, right? So the longer that the dopamine's in the synaptic cleft, the more that it can continue to stimulate the postsynaptic cell, right? So we have kind of that reward pathway continues to be activated because the dopamine's not part of and is no longer in the reuptake process, the normal reoccurring reuptake process that occurs for that cell. And so you'll see that this mechanism occurs across a variety of substances, and your text goes into greater detail about that. The next substance, we have cannabis. So the most popularly used illicit drug. So we have marijuana. This is a psychoactive substance that's derived from the hemp plant, whose primary active ingredient is delta tetrahydrocannabinol, and this is popularly known as THC. So you may have heard THC thrown around before. There's also hashish. This contains a more potent form of THC and still comes from that plant's flowers. THC can certainly be used for medical purposes. This is gaining increasing support across a variety of states. It's often used for asthma, glaucoma, also used to treat nausea in cancer patients who are undergoing chemotherapy. It's important to note, there's often a misconception with cannabis that even though it may not be as harmful as some of the other substances, that it's not without some adverse physiological outcomes. It can produce a variety of effects on bodily functioning. Can lead to higher risk of experiencing a heart attack, can lead to impaired respiratory functioning, and some problems with executive functioning. So your text goes over this just in terms of some of the problems with decision making, inhibition, and impulsivity, and verbal fluency. Right. So certainly this drug isn't necessarily going to have some of the effects of intensive cocaine use, but it's important to recognize that there are some mixed findings that exist on executive functioning that comes about with marijuana use and with cannabis use. So just so you're aware of that comes about, and like I had showed you earlier, cannabis use is often correlated with a variety of other mental health conditions. Again, correlated, not necessarily, and likely not causational. We also have hallucinogens. So these are going to be psychoactive substances that cause abnormal perceptual experiences, and these are generally in the form of illusions or hallucinations, and these are usually visual in nature. There's LSD. This comes in the form of either tablets, capsules, or in liquid form. There's peyote and psilocybin, psilocybin being found in certain types of mushrooms, and PCP or angel dust. This is originally actually developed as an intravenous anesthetic. With the PCP, you'll see symptoms that will often mimic schizophrenia, right? So we have mood disturbance, memory loss, difficulties with speech and thinking, weight loss, and depression, on top of the some of the psychotic symptoms that might come about. And there's also MDMA. So this is what would be known in the street as ecstasy. This is a synthetic substance that's chemically similar to methamphetamine. People who are using MDMA would often experience feelings of increased energy or euphoria, emotional warmth, distorted perceptions and sense of time, and unusual tactile experiences, right? So we'll have some of that, the tactile hallucinations may come about. There's often a variety of unpleasant psychological effects that come about from hallucinogens, including confusion, depression, sleep problems. So these guys certainly aren't without their side effects. Opioids are the next drug. These are psychoactive substances that relieve pain. For any of you in Western Massachusetts, you might have heard actually that there's actually quite a bit of a problem with opioids right now. It's increasingly becoming a problem. So within these disorders, you're going to see intoxication, opioid use problems, and withdrawal. And originally clinicians prescribe a variety of these to treat pain, right? So some of these drugs might be used to prescribe to treat dental pain or injury-related pain. Physicians will use hydrocodone for dental and injury-related pain. Morphine is often used for surgical procedures, right? So when we get down to heroin, one of the more popular opioids, this is a form of an opioid synthesized from morphine. A really big problem. It often leads to fatal overdoses, can lead to infectious diseases, and even if it's not fatal, it generally leads to damage to the cardiovascular system, or liver or kidney disease. So your text talks a little bit more about this, but this is actually a really hot button issue. If any of you are planning to go into nursing or public health in the New England area, you'll see that this is an increasing problem. There's a variety of other substance use disorders that occur in terms of sedatives, hypnotics, anxiolytics, and inhalants. So sedatives generally have a calming effect on the central nervous system, right? We have hypnotics that include sleep. So you might see Ambien or Lunesta might be abused here. Anxiolytics are anti-anxiety medications. Oftentimes, you'll see people taking these medications without a prescription. And then there's a variety of inhalants, and inhalants are a bit diverse. They're a group of substances that can cause psychoactive effects, specifically by producing chemical vapors. And they generally have similar effects to alcohol. And you'll see oftentimes a slurring of speech, a loss of coordination, euphoria that might come about, dizziness, and over time you'll see loss of inhibition and control. In terms of some of the theories here, your book goes into a little bit more detail in terms of some of the genetic abnormalities that come about here, so a little bit more nuanced, and similar to alcohol, to treating alcohol abuse, there are some substances that exist to treat specifically some of the opioid problems, including methadone and naltrexone. Excuse me. In terms of some of the theories and treatment from the psychological point of view, we'll see contingency management, so an if-then kind of approach. We'll see this oftentimes occur in inpatient programs. There's a variety of principles of treating substance dependence other than alcohol through CBT. These are similar to those that are involved in treating alcohol dependence, so we'll see a lot of the CBT approaches coming about. And we'll see the same kind of thing, clinicians combining CBT with those motivational therapies that focus on contingency management, right? So we'll see a lot of psychotherapy integration that's occurring here, and that's done across modalities in terms of integrating the more behavioral approaches like CBT with the humanistic approaches like motivational interviewing, but that's also done across not just the treatment orientations, but the specific modalities themselves. So whether that's a group approach, inpatient approach coupled with community outpatient work, there's a variety of places there. So if any of you are interested, in continuing in this work, there's a variety of ways in which you can do it, whether that's in the hospital setting or the outpatient setting, and across, different theoretical orientations. So there's certainly a lot of room for, different career opportunities here. So, gambling disorder is often linked with the substance use disorder. This is obviously a non-substance related disorder involving the persistent urge to gamble. And it's now included with substance use disorder because it's conceptualized as showing many of the same behaviors as the other substance use disorders, right? So we have like the experience of cravings, the increasing need to engage in the behavior, and negative social consequences that can come about. So the loss of family, loss of financial security, other forms of impairment that can come about. Similar to the other substance use disorders, we see a wide variety of comorbidity. So we see nicotine dependence, substance use dependence, and then again, not surprisingly, the mood and anxiety disorders, which are coupled together as they are in the other substance use disorders. Interestingly, mood and anxiety disorders are more likely to precede rather than follow the onset of gambling disorder. So you'll see this more so than you might see in maybe some of the other substance use disorders. There's a variety of cognitive distortions if we're coming at this from the psychological point of view in gambling disorder, and you can read a little bit more about these in your text. So just in terms of looking at the biopsychosocial perspective, there's obviously a lot that goes into the substance use disorders. A variety of treatment programs for people with substance-related disorders have emerged. So again, thinking about inpatient versus outpatient, motivational interviewing coupled with cognitive behavioral approaches, and pharmacological intervention associated with social support. Biological treatments may involve the prescription of specific substances that block or reduce specific cravings. So again, like the antabuse to cut down on alcohol treatment, methadone used in terms of treating opioid problems. And behavioral treatment involves techniques again such as contingency management, CBT, or relapse prevention. And perhaps one of the most important places for this to take place would be at the sociocultural level. So interventions that rely on the social support systems that include sober family members, sober friends, and community organizations such as places of worship, and other areas that foster a sense of community and social support. So there's a lot that go into substance use disorders. Again, this course is only going to scratch the surface here. You could take a whole course on these specific disorders, but hopefully this gives you guys an overview of what some of the accompanying symptoms of those disorders look like, and an overview of some of those treatment approaches.